Coming to you live from AHA 2025, this is Ginger Jiang with Mike Gibson, and we're here today to discuss the Celebrate trial investigating pre-hospital treatment with platelet inhibitor Zalunfiban. So, Mike, we've come to learn that Zalunfiban is a glycoprotein 2b3A inhibitor that's administered via subcutaneous injection. And as we know, somewhere between a third and a half of MI deaths occur prior to the patient reaching the hospital. And so the rationale behind this trial design is that rapid reperfusion may be key to improving outcomes in STEMI. So what were the major findings?
Yeah, we know time is muscle, and we wanted to accelerate that. We wanted to move care into the home. We still have a lot of delays getting people to the hospital. Do a great job when they hit the hospital door, but we still have delays getting to the hospital and getting from one hospital to the other. So the goal was to see, as you just said, if we got arteries open earlier, would we improve outcomes? Now, we've known for 30 years that getting arteries open earlier and with better flow improves outcomes. We found that that was the case here in 2,500 patients, that giving this 2B3 inhibitor subcutaneously did open more arteries on arrival to the cath lab, number one. Number two, does that pass the whole hum test? Did it improve the primary endpoint of improving death, MI, stroke, stent thrombosis, heart failure, or a large heart attack in a hierarchical analysis, something called a proportional odds model? And the answer was yes. It reduced any of those adverse endpoints by 21%, which was statistically significant. Now, the flip side to that is how many people were alive and endpoint free? And the answer is about 3.5% more. So you'd only need to treat about 29 people to have, an additional event-free survival. Now, the penalty is always possibly an excess risk of bleeding. In this study, we found no difference in gusto severe or life-threatening bleeding. There was an uptick in mild to moderate bleeding, most of it at the access site. So, what has changed since we did many of these studies back in the 90s and early 2000s? We now do the majority of our cases by the radial approach. And that, of course, reduces the risk of those large femoral bleeds and those retroperitoneal bleeds that we saw in the past. So, safer approach through the radial approach, and okay to give, in this case, this specific 2B3A inhibitor, a 2B3 inhibitor that is largely not renally cleared. And that is in contrast to integralin and aggrastat that are renally cleared. So people might say, well, these endpoints, stent thrombosis, infarct size, all that, those are soft endpoints. What we found is all those endpoints, stroke, stent thrombosis, heart failure, and infarct size, were all related to mortality in this study. So I do think that I think they are good surrogates in this type of study. So I think we improve flow, that in turn we can show improved the size of infarcts, both clinical heart failure and infarct size. And when you put it all together, improved efficacy. It came at the cost of more mild bleeding. There were no excess GI bleeds, no excess ICHs, and no excess severe or life-threatening bleeds. So overall, I think it is a positive benefit.
Mike, that's incredibly exciting. So, as you mentioned, the primary endpoint was a ranked 7-point scale of outcomes. And we've seen that many studies these days have moved towards using these sort of ranked composite outcomes. So, how should we think about the selection of this sort of endpoint?
Well, I think this was not a win ratio. It was specifically a little different than a win ratio. It's a proportional odds model. People can be skeptical of win ratios, but what we found here is that the majority of the endpoints moved in the right direction. You don't want it all driven by the anchoring endpoint, say in this case, infarct size. We also saw things go in the right direction for heart failure. We also saw a significant reduction in stent thrombosis. So when all the endpoints are lining up in favor, that shows you that there's consistency of benefit. I think that gives you the confidence that you need. If you do a trial where it's all driven by the biomarker endpoint and things go the other way clinically, that would not give you confidence. But this was different. This all lined up.
That's all very promising. And how would you think about these results within the context of everything that we already know about GP2B3A inhibitor use in ACS?
Well, it's interesting. Your generation has not used these drugs as much. My generation, we used them a lot. I think there was pushback though, because we were doing a lot of femoral cases with larger sheaths. We had a lot of femoral site bleeding, long compression times, pseudoaneurysms, retroperitoneal bleeds, which were very scary, and in some cases fatal. So the other issue is that some of those drugs, Aggrastat and Integralin, were renally cleared. You can't dialyze off Integralin, for instance. Now, ReaPro you can give, but the other two you can't. So one of the refreshing things here is we have potentially, if it's FDA approved, another agent that will be, uh, you know, potentially safe. We have to look more in larger samples, potentially safe in those patients with renal insufficiency. This drug is not given IV. It's given under the skin. It's given sub-Q. That makes it easier to be given at home, unlike our early trials of 2B3 inhibitors where you had to put an IV in and, it makes it much more complicated. Ultimately, someday, Ginger, with a sub-Q approach, we might be able to study this as a self-injected drug for heart attack survivors. And you could start therapy anywhere.
Well, that's an absolutely exciting update that certainly will generate a lot of buzz. So thank you very much, Mike, and thank you all for joining us live from AHA 2025.
Thanks for having me on, Ginger.